In a previous video, we had seen mediastinal staging of non-small cell lung cancer. Our main aim was to rule out N2 disease because patients with N2, that is mediastinal metastatic lymph nodes, would require multimodality therapy, which may or may not include surgery. The role of surgery in patients with N2 metastatic lymph nodes in non-small cell lung cancer in itself is a very vast area which will be covered in a subsequent video. The management of stage 3 and advanced tumors will be discussed in a subsequent video. In this video, we'll be discussing in short the management of early stage non-small cell lung cancer, which pretty much includes tumors of up to 5 centimeters in size with N0 or N1, that is only hilar lymph node positive, mediastinal lymph nodes are negative. So we'll be discussing this in two halves, stage 1 and stage 2. Stage 1 is basically a tumor of up to 4 centimeters in size, that is T2A, with a node negative mediastinum. So by node negative mediastinum, we mean that a PET does not show any mediastinal lymph nodes, and in some patients who had central primaries, we may have done an invasive mediastinal staging also. As discussed in the previous video on mediastinal staging, patients with tumors peripheral lung tumors that are less than 3 centimeters in size and a radiologically negative mediastinum, and invasive mediastinal staging may be omitted. So, at the end of clinical staging, we have a patient who is stage 1 or stage 2, that is up to 5 centimeters and node negative or maximum only hilar nodes positive. The management of such patients is surgery, lobectomy plus sampling. For stage 1, systematic mediastinal sampling is an accepted method of lymphadenectomy. We'll be discussing lymphadenectomy again in detail. At least 3 mediastinal stations have to be sampled. By mediastinal stations, we mean stations 2 to 9 and not the hilar, interlobar, and the subsequent intrapulmonary nodes. Now, interestingly, last year, two very large RCTs were published, CalGB 140503 and JCOG 0802. They were widely talked about. Earlier, patients with prior pulmonary comorbid conditions which would affect pulmonary functions post lobectomy were treated with a segmentectomy, a sublobar resection. So these were done for unfit patients, but the oncological equivalence or non-inferiority was studied in these two trials. First in CalGB 140503, tumors less than a centimeter, peripheral non-small cell, uh, underwent segmentectomy or a lobectomy, randomized control trial, and sublobar resection, that is segmentectomy, was non-inferior to a lobar resection in terms of DFS and OS. They had a good 7-year follow-up, and this was 5 years DFS and 5-year OS. Very similarly, in JCOG trial, again a phase 3 RCT, tumors up to 2 centimeters node negative, a large number of patients. At 5-year OS was pretty much the same, 94% for segmentectomy and 91% for lobectomy, proving that segmentectomy is non-inferior to lobectomy oncologically for small tumors that are node negative. So lobectomy may continue to be the standard of care, but segmentectomy may be considered to be oncologically non-inferior and it can be performed without any doubts. Now, we have done the primary. Now, lymphadenectomy. It's a very interesting area. It's a hugely debated area. For example, in CS stomach, it was found in a randomized control trial that D2 lymphadenectomy was better than D1 lymphadenectomy in reducing recurrences and in prolonging survival of patients. So the radicality of surgery improved chances of cure. But D2 plus routine para-aortic lymphadenectomy and all that, the D3 lymphadenectomy, what is called in Japan, was not better than D2 in providing additional overall survival. So the limit was D1 better than D2 better than D1, but D3 was not required. So the standard of care continues to be a D2 lymphadenectomy. In breast, for example, everyone now tries to preserve the axilla. Initially, it was a radical mastectomy with complete clearance of all lymph nodes up to station 3 and level 3. And now everybody is concerned talking about SLNB and axillary conservation even after neoadjuvant chemotherapy because of the disastrous complication of lymphedema after routine axillary sampling. And axillary preservation has been found to be oncologically non inferior in several groups of patients. In kidney, for example, unless a clinico-radiologically abnormal enlarged lymph nodes are there, there is no role for performing a lymphadenectomy. Only radical nephrectomy is the standard of care. This was also proved in the Gershman trial. Whereas in penis, the most important part of the treatment and the most important predictor of survival is how we achieve control in the lymph nodes. If we fail in the lymph nodes, we fail the patient will have distant metastasis and a poorer survival. So we have to be very aggressive about management of lymph nodes in CA penis. So such is the concept of lymphadenectomy. For some cancers, it is done only for staging. Some cancers, it is done as a therapeutic procedure. In lung also, it is a hugely debated area. So how the management of lymph nodes has evolved for non-small cell lung cancers over the past few years. So this is the lymph nodal map. Stations 2 to 9 constituting the mediastinal lymph nodes, station 10 to 14 constituting the intrapulmonary and hilar lymph nodes. In 1995, R.J. Ginsburg, in his paper, established systematic mediastinal lymphadenectomy, lymph node dissection, as the gold standard, which he it was found that systematically removing all the mediastinal lymph nodes within anatomical boundaries provided improved overall survival for patients with non-small cell lung cancer. But again, this was an era where chemotherapy, the current chemotherapy drugs were not given, and the indications for adjuvant chemotherapy were different. The adjuvant TKIs and immunotherapy drugs were not there. So this was a different era, but back then this established systematic mediastinal lymph node dissection as the standard of care. So this was followed in a lot of guidelines till 2006, 7, 8, where ESTS, ESMO, and IASLC recommending mediastinal lymph node dissection. Then came the thought: can we do something lesser than a systematic lymph node lymphadenectomy? Can we do something less morbid than complete removal of all mediastinal lymph nodes? Because the main complications of removing all mediastinal lymph nodes are related to nerve injuries, because the RLN and the vagus pass very close to the lung hilar in the mediastinum, and we have postoperative chylothorax as a complication of lymphadenectomy. And there is also another complication: routine removal of station 7 lymph nodes can lead to ischemia of the carinal area. So all these complications were happening, and people thought, why not do something lesser? So then came the concept of sampling. So the first randomized trial in this aspect was by Wu and allies for stages 1 to 3A NSLC. So what they did was they explored stations 1 to 9 thoroughly, but they removed only the enlarged lymph nodes. But they always removed station 7 because it is thought that station 7 is an early harbinger, an early site for metastasis from all lobes of lung cancers. But in this trial, mediastinal lymphadenectomy proved to be better than sampling in terms of OS and DFS. Patients with sampling had higher recurrence rates and a lower overall survival. The second RCT to mention is the ECOSOG Z0030. In this, uh, lesser staged patients, so tumors up to 5 centimeters, T1 and T2 tumors with N0 or non-hilar N1. So N1 is basically 10, which is hilar, 11, 12, 13, 14, interlobar, lobar, pulmonary, subsegmental, and segmental. So apart from station 10, if patients had lymph nodes only in 11, 12, 13, 14, they were included. And otherwise, N0 patients were only included. They did a rigorous preoperative sampling of stations 2R, 4R, 7, and 10R for right, and these stations were for left, and all abnormal lymph nodes, be it station 8, 9, or 6, or whatever it is, they were sent for frozen section. And if negative on frozen section, the sampled nodes were negative on frozen section, then the patients were randomized. No additional lymphadenectomy, or proceed with the conventional gold standard of lymphadenectomy. So after such rigorous staging, basically what is happening is pathologically node positive patients are excluded from the trial, are excluded from the randomization. So the basic concept of intention to treat is lost. So only patients with pathologically negative mediastinum were then randomized, and there was no benefit of systematic lymphadenectomy over and above sampling. So both had equal overall survival. So the conclusion of this trial was that There was no additional benefit of lymphadenectomy over and above sampling, provided such rigorous sampling of mediastinal lymph nodes are performed, and these are negative on frozen section. So the authors would still recommend a mediastinal lymphadenectomy because it does not cause a significant increase in morbidity over and above sampling. The second concept of doing lesser than a mediastinal lymphadenectomy was the lobe-specific lymphadenectomy. This is commonly practiced in the East, Japan, Korea, China. So for right upper lobe tumors, stations 2R, 4R, 7, and so on, these are the stations that are extensively studied and lymph node mapping done in so many patients, and it was found that tumors from this primary, for example, a left lower lobe primary, would have the highest propensity of metastasis only in station 7, 8, and 9. So, a lobe specific lymphadenectomy, ignoring the other mediastinal lymph node stations, was considered. The first prospective trial was a non randomized trial by Okada and Allies, and this trial showed a non inferiority of lobe specific lymphadenectomy in terms of overall survival and DFS at 5 years. There's only one RCT in this subject, excuse, which had only 96 patients of very small size tumors, T1A tumors, T1 actually less than 2 centimeters, T1A is less than 1. So less than 2 centimeter tumors, there was no difference in survival or recurrence or end stage migration with lobe specific lymphadenectomy. So the conclusion of this trial was that lobe specific lymphadenectomy can be considered in such small tumors. So basic summary of the evidence that's available. So this lobe specific lymphadenectomy is non-inferior to systematic dissection only in stage 1 tumors, very early tumors. This Darling and Allies is the ECOSOC Z30. If systematic sampling is done, thoroughly done, and it does not show any metastatic lymph nodes, frozen negative, then mediastinal lymphadenectomy can be avoided in again early stage tumors, T1 to T2, N0 tumors. This is an ongoing trial in Japan. The results are expected in 2026, and this will shed more light on the benefits of or the non-inferiority of non-lobe specific lymphadenectomy for early stage tumors. So these are some systematic reviews and meta-analysis. Only one is worth mentioning. It's a recent paper. Selective mediastinal dissection, that is lobe-specific lymphadenectomy, is preferable in stage 1 as per this meta-analysis. But this is to be taken with a pinch of salt because the studies that were taken in this meta-analysis are very varied, and there's a lot of bias, publication bias, and all that going on in this meta-analysis. So the summary is, if we have a patient with stage 1 T1 or T2A N0 tumor, the patient should undergo a lobectomy with systematic mediastinal lymphadenectomy as the standard of care. Anything lesser than a lobectomy, yes, segmentectomy can be considered for tumors up to 2 centimeters. We have level 1 evidence for that. Anything lesser than a systematic mediastinal lymphadenectomy, yes, sampling can be considered for very early tumors, less than 2 centimeters, 3 centimeters, as per the ACOSOC Z0030. And lobe specific lymphadenectomy can be considered, but it's usually performed in the east. Sorry. Non-surgical options. Patients are not fit for surgery at all. Multiple comorbidities, pulmonary functions are not good, chronic smoker, emphysema lung. So post-operatively, pulmonary complications are going to be very high. So there are two options: radiation and ablation. So in radiation, the morbidity is lesser compared to surgery in such unfit patients. So we are compromising on the oncological outcomes because we don't have a choice. 10 to 20% lower 5-year overall survival. In a fit patient, if the patient comes and asks us, can I undergo SBRT instead of surgery? The answer is a definite solid no. Surgery is superior. SBRT is oncologically inferior in fit patients. It provides lower overall survival till the results of Valor trial come out in 2026. The answer remains no. Ablation is another non-surgical option. Again, 20% risk of pneumothorax is there. Grade 3 morbidity can happen. Again, very low overall survival, 20% lower 5-year overall survival compared to a sublobar resection, not even a lobectomy. But still, if you don't have any other option, it can be kept in the back of our mind. Adjuvant therapy for stage 1. In stage 1A, that is less than 3 centimeters, if R0 resection, margin negative resection, and no high risk features, no adjuvant. But the evidence for this is indirect. It comes from many trials which did not include stage 1A patients. And in CalGB 9633, 1B had overall survival with adjuvant chemo, but not 1A. So in 1A, patients can be observed if margin negative and no high risk features. Stage 2. Now, stage 2 patients are tumors 3 to that is this is our stage 2 patients. They can be tumors up to 5 centimeters with N1 lymph nodes. How do we treat them? The standard of care is lobectomy with mediastinal lymphadenectomy complete. There is a definite survival advantage of complete lymphadenectomy over sampling. So, sampling or lobe specific lymphadenectomy should not be considered as standards of care for stage 2 patients at this point. And without doubts, these patients should receive adjuvant. Strong evidence from the LACE meta-analysis, which showed a 5.4% increased 5-year overall survival with adjuvant platinum-based chemotherapy. Again, an RCT which showed chemo provided improved overall survival in stage 2 patients. Adjuvant TKIs. So this is a trial, the Adora, in patients with stage 1B to 3A. So stage 2 was also included. If the patients had EGFR mutations, osimertinib were compared with placebo in a randomized controlled trial, and adjuvant chemo was not required as a part of mandate. It was administered in 60% of patients in both arms. The 2-year DFS was remarkable, 90% in patients who received osimertinib versus 44% in patients who received placebo. So irrespective of adjuvant chemo is the key. So adjuvant immunotherapy in IM Power 010, stage 1B to 3A, again stage 2 was included. So patients received adjuvant 4 cycles chemo, and if there was no progression after chemo, they were randomized to atezoli versus observation. There was improved DFS in patients with a PDL1 composite score more than 1%. There was no improvement in patients with EGFR mutation. So the summary is, in stage 2, all patients should receive cisplatin based adjuvant chemotherapy. There's no doubt about it. If the patients are EGFR mutants, they can be considered for osimertinib. If the patients have PDL1 more than 1% composite score, and if they are EGFR wild type non mutants, they can be considered for atezoli. This based on Adaura, this based on IM Power 010. Neoadjuvant setting also, immunos and TKIs are being tried in Neo-Adora and a few other immunotherapy trials, but those are beyond the scope of this video. We'll discuss this in the subsequent video. Is there any role for radiation in stage 2? No. In an R0 resection, there is absolutely no role for postoperative radiation, even if the final histopathology shows mediastinal lymph nodes. So how will this situation happen? We did an EBUS, which was negative. We did a mediastinoscopy, which was negative. Then we proceeded with the resection with the mediastinal lymphadenectomy, and we submitted the final specimen for HPR. The final HPR 1 or 2 mediastinal lymph nodes are positive in stations 2 to 9. Even then, the final the histopathological stage becomes 3A, but as long as this patient has undergone an R0 resection, there is no role for radiation based on lung art and port C.